Okay, good afternoon, students. Today we'll be looking at another chapter in our MedSurg text, and this will be management of patients with dysrhythmias and conduction problems. Okay, so let me go to slideshow for you. Now we're first going to look at how electrical impulse is conducted through the heart, or we're going to remind ourselves of this because we have looked at this before, the conduction of an electrical impulse. And the knowledge of this conduction is really necessary to understand our dysrhythmias and our conduction abnormalities. We said that impulse is generated in the SA node, and from the SA node, the impulse moves to the AV node, and then to the bundle of His, and then to the right and left bundle branches, to the Purkinje fibers, and the Purkinje fibers surround the ventricles and contracts the ventricles or the myocardium. Okay, we had looked at diagrams about this already. And so this is just a reminder as we go into our dysrhythmias and our conduction problems. We said depolarization leads to stimulation of the heart and leads to contraction or systole. Repolarization is when the heart relaxes and it leads to diastole. Okay, so bear those concepts in mind. Normal conduction, as we described, is when the electrical impulse that stimulates and paces the cardiac muscle normally originates in the SA node, and that's how normal conduction through the heart is initiated, or impulse or electrical signal through the heart, that's how it's initiated, okay? It starts in the SA node, and it's an area located near the superior vena cava in the right atrium. When we did assessment of cardiac function, we already did all of this. I'm just going it over as a review. In the adult, the electrical impulse usually occur at a rate of 60 to 100 times per minute. And thus your normal heart rate is about 60 to 100 beats per minute. The electrical impulse quickly travels from the SA node through the atria to the atrioventricular node. And this process is known as conduction. The electrical stimulation of the muscle cells of the atria causes them to contract. The structure of the atrioventricular node slows the electrical impulse when it reaches there, so it gives time to the atria to fully contract and empty its content down into the ventricles. This part of the atrial contraction is frequently referred to as the atrial kick and accounts for nearly 1/3 of the volume of blood ejected during contraction. The electrical impulse then travels very quickly to the bundle of His from the AV node, and then to the right and left bundle branches, and then to the Purkinje fibers located in the ventricular muscle. So here again, you get a nice little summary of the conduction of impulse through the heart. Now we're going to move right into our dysrhythmias. Dysrhythmias are disorders of formation, conduction, or both of electrical impulse. So if you have a disorder, formation of the electrical impulse, or a disorder in the conduction means that it's not conducting as it should, then that's what we call dysrhythmia. Without a regular rate and rhythm, the heart may not perform efficiently as a pump to circulate oxygenated blood to the body, okay? And when you have dysrhythmias, remember that the conduction of impulse is going to be affected, or the formation of the impulse is going to be affected. And so if that is affected, the contraction, the regular rhythmic contraction of the heart is going to be affected. It's going to affect the rhythm, it's going to affect the rate. So with an irregular or erratic rhythm, the heart is considered to be dysrhythmic. That's what dysrhythmia is about. An irregular rhythm or an erratic rhythm. And it is also called arrhythmia. This is a potentially dangerous condition, as we're going to see a little later. It can cause disturbances of rate, it causes disturbances of rhythm, or it can cause both rate and rhythm to be disrupted. It can potentially alter blood flow and cause hemodynamic changes, because if you know that your rate is affected, say your normal heart rate is 60 to 100, but now your heart rate is 40, okay? That's a disruption in the rate. And if your heart rate is 40, you're not going to have as much cardiac output as if your heart rate was 60 to 100. So it can alter blood flow, and it is diagnosed by analysis of the ECG waveform. We're going to be looking at different ECGs also. Dysrhythmias are named according to the site of origin of the electrical impulse and the mechanism of formation or conduction. We said that already. So from the sinoatrial node, you can have, and these are the common ones that you'll see. I did go into a little more than these. So from the sinoatrial node, you can have a sinus bradycardia. What does that mean? Brady means slow, okay? So a sinus bradycardia, it's gonna appear like a normal rhythm because you're gonna have all the components of your ECG rhythm. It's just that it's gonna be slow, okay? So for a sinus bradycardia, you can just think of your pulse rate being slow. A sinus tachycardia, similar again to a normal rhythm with all the components of the ECG, but it's gonna be fast, okay? Atrial rhythms, you may have premature atrial complex, atrial flutter, atrial fibrillation. And your ventricular rhythms, premature ventricular complex, ventricular tachycardia, ventricular fibrillation, ventricular asystole. And also, I must say, we do have other rhythms that fall under premature ventricular complexes, like your ventricular trigeminy, ventricular bigeminy, okay? And also your torsades points, which we'll look at a little later. The electrical impulse that travels through the heart can be viewed by means of an ECG, and you may see it referred to as EKG also, means the same thing. An ECG is obtained by placing electrodes on the body in specific areas, and the electrodes have two components, an adhesive substance that attaches to the skin to secure the electrode in place, and a substance that reduces the electrical impedance or the skin's electrical impedance. So we need to have a transmission of that electric activity or electrical activity from the body to your ECG. And so we want to reduce impedance or blocking of the electrical impulse. So gentle abrasion with dry gauze expose the inner conductive layer of the epidermis, which will reduce the skin's impedance or the skin's blockage. Chest hair should be clipped, and do not place the electrodes over bony prominences because that will block the electrical conductivity. Electrode placement, continue. The number and placement side of the electrodes depend on the type of ECG that you're trying to obtain. Most continuous monitors use 2 to 5 electrodes, and these are usually placed on the limbs and the chest. These electrodes create imaginary lines called a lead, which serve as a reference point from which the electrical activity is viewed. Now, a lead is like the eye of a camera. It has what we call a very narrow peripheral field of vision, so it can only see what is in front of it. Okay, so it looks at the electrical activity directly in front of it. And that's why we have to have different leads, because we're not going to view the heart from one direction. The different leads allow us to view the heart from different angles. So therefore, the ECG waveform that appear on the ECG paper and cardiac monitor represents the electrical impulse in relation to the specific lead. And if you look in your book, it's going to be figure 26:1. For a standard 12-lead ECG, 10 electrodes are placed, 6 on the chest and 4 on the limbs. To prevent interference, as we said, with the conductivity, the limb electrodes are placed on areas that are not, great job, that are not bony and that do not have significant movement. The limb electrodes provide the first 6 leads. Lead 1, 2, 3, AVR, which is your augmented voltage right arm, AVL, which is augmented voltage left arm, and AVF, which is augmented voltage left foot. So those are your 6 leads for your limb electrodes. The 6 chest electrodes are applied to the chest at very specific areas, and the chest electrodes provide your precordial leads. Here you see the chest electrodes. Where's my pointer? Here you see the chest electrodes. And as we said, they are placed at specific point, sometimes based on what the examiner wants to view. You have what they call supplemental precordial leads that they place in different places. The ECG contains waves, complex, and intervals, and we're going to be looking a little closer at the ECG waves, the ECG complexes, the ECG intervals. The waveforms include P wave, QRS complex, T wave, and sometimes a U wave is present. Not all the time, but sometimes a U wave may be present. If it is not present, it's not such a big deal, okay? But sometimes it is present, and we'll explain that in a little while. The P wave represents atrial depolarization. Now, when we did our action potential, we did depolarization, repolarization, action potential, okay? So the P wave represents atrial depolarization. And remember, atrial depolarization occurs before atrial contraction, okay? So if you try to remember depolarization, contraction, depolarization, contraction, it will give you a little perspective on what we're talking about when we refer to depolarization. Remember depolarization, some books use it synonymously to contraction. Okay, so bear that in mind. So the P wave represents atrial depolarization. As I say, some books will say atrial contraction. Okay, it is normally 0.11 seconds or less in duration. The QRS represents ventricular depolarization or ventricular contraction. It is normally 0.12 seconds in duration. So you see that the width of the P wave and the width of the ventricular wave is similar. Width of the atrial wave, width of the ventricular wave is similar. One is 0.11, one is 0.12. The T wave represents repolarization of the ventricle. Remember we said that after depolarization, which is contraction, the heart has to rest, right? Or the ventricle has to rest. Repolarization leads to rest. The U wave is rare, but sometimes it is seen in hypokalemia. So those are your waves. Now, your interval, your PR interval is measured from the beginning of the P wave, because we're talking about PR, P wave to the beginning of the QRS, okay? It normally ranges from 0.12 to 0.20 seconds. Bear this in mind, especially the measurement, because when we go to the heart blocks, we're going to see what is happening to our PR interval. The ST segment, which represents early ventricular repolarization, lasts from the end of the QRS complex to the beginning of the T wave. Let's look a little bit on some pictures to make this a little clearer. Okay, we talk about our P wave. Let me pull up my pointer. So we talk about our P wave. So here we see our P wave, okay? And we said the P wave represents, what did we say it represents? Atrial depolarization or atrial contraction, okay? So atrial contraction, evidenced by our P wave. And you notice how small it is or how short it is in relation to the ventricle? They're basically the same width, okay? Because the P is 0.11 across here, while the ventricle is 0.12 across here, okay? So we said that this is our atrial contraction, okay, or depolarization. And the QRS is our ventricular contraction or our ventricular depolarization. So look at your QRS. And then the T wave is ventricular repolarization. So the ventricle contracts and then it goes to rest. The atria contracts and it rests also, but we're not seeing atrial resting or atrial repolarization on this ECG. Why are we not seeing atrial repolarization? That's a question that students ask all the time, so thanks for asking. We are not seeing atrial repolarization on the ECG because it is hidden behind this large ventricular contraction. So if we didn't have the ventricle contracting here, we would have seen the atrial repolarization or the atrium going back to rest, okay? But it is hidden behind this complex, your QRS complex, okay? So once again, or P wave, atrial depolarization or contraction, or QRS, ventricular depolarization or contraction, or T wave, ventricular repolarization or resting. Atrial resting is hidden behind our ventricular depolarization or QRS wave, okay? So if I say atrial systole, you're looking at your P wave. If I say ventricular systole, you're looking at your QRS complex, okay? All right, so you see these boxes. First, before I go to the boxes, remember we talk about our waves, and I'm sure you understand now your waves. And then we talk about our intervals, okay? Because the intervals can tell you if this patient is having a heart block or a dysrhythmia, okay? So your interval, this is your PR interval, okay? And this is your PR interval is from the beginning of your P wave to the beginning of your QRS, okay? So it's PR, it's referring to this R, okay? And then your QT interval is from the beginning of your Q wave to the end of your T wave, okay? So that's your QT interval. Okay. So you may hear about your ST segment. Your ST segment is from your S wave to your T wave. That's your ST segment. Okay, because when you go to your myocardial infarction, and so that we have done those already, you will see ST segment elevation. Okay, it means that this area, instead of being on what we call the isoelectric line, it is elevated above the line. It would be above the line. The isoelectric line really is an imaginary line that you can imagine that goes across. Say you're looking now at your PR interval. If you draw a straight line across, that would be your isoelectric line. And you do have some waves above the line and some below the line. Your Q and your S is usually below the isoelectric line. Your P, your R, your T would be above the isoelectric line, okay? All right, so let's now look on the boxes. One big box measure 0.2 seconds, or you can have 0.2 seconds. A big box is the entire shaded area or the pale area where you see these lines. So these are big boxes, okay? And one big box measure 0.2 seconds. Now, one small box is 0.04 seconds. So in one big box, you have 1, 2, 3, 4, 5 small boxes. So you count across, okay? So you have 5 small boxes across for one big box, okay? One small box measure 0.04 second. You do have 5 small boxes that make up one big box. So even if you multiply 5 by this, by 0.04, you're going to get 2, okay? All right, so those are your boxes. Bear them in mind. You can also use your boxes to check how wide the P wave is. And that's the importance of knowing the measurement of the boxes. You can use them to check how wide the P wave is, how wide your QRS wave is, and so forth. You can use it also to check your intervals. All right. So that's your normal look of your ECG, P, Q, R, S, T, and sometimes a U. All right, so how do we analyze this ECG strip? This is the exciting part. We're gonna analyze ECG strip by starting very simply. We're gonna try to determine the heart rate using the strip. And one way to determine the heart rate is to count the number of RR intervals on the strip and then multiply that by 10. So make sure you're taking notes. Count the number of RR interval in the 6-second strip. Usually a strip, it runs for 6 seconds, okay? It's just like counting your pulse. If you count your pulse for, say, 15 seconds, how much would you multiply that by to get your heart rate? Think about it. Count your pulse for 15 seconds. You want to get your pulse rate, but you don't have time to count it for a minute. So you count it for 15 seconds. What would you multiply it by to get your pulse rate per minute? I hear some people saying 4, and that is correct. Now, if you're counting that same pulse for 6 seconds, what would you multiply it by to get your pulse rate per minute? Think about it. And I do hear some people say 10. Okay, so consider your 6-second strip, okay, as counting your pulse for 6 seconds, okay? And so you count the number of RR intervals. Let's go to it. These are your RR intervals. So between this one and this one, that's your first interval. Some books will tell you you count all your R waves. Remember your P, Q, R, S. So this would be your R wave. Some books will tell you that you count the R waves, but that's not absolutely accurate. What your text say is that we count the interval. So from one R wave to the next R wave would be one interval. So all of these are your R. So you count the R interval. So from here to here would be 1. From here to here would be 2. From here to here would be 3. Okay. So if this was a 6-second strip, consider that this is a 6-second strip, and we only have 3 intervals. What would that heart rate be? Remember, what you multiply by is going to be multiplied by 10. So it's like you're counting your pulse for 6 seconds and multiplying it by 10. I got 3, okay? So that means your pulse rate would be 3 times 10. Your pulse rate would have been 30, okay? So determine the rate. Remember, we're doing the heart rate. We're determining the heart rate by the RR intervals. Again, count the number of RR intervals on your 6-second strip and multiply that number by 10. So 7 RR intervals in 6 seconds is going to be 7 times 10. So your pulse rate would be 70. Okay. Now, that's one way of counting your heart rate. The next way of counting the heart rate is to determine the rate by counting the large boxes. So we have 3 basic ways of counting the heart rate from the ECG. Already you learned one. Let's learn the second one. We can count the number of large boxes between the 2 R waves and divide 300 by that number. Let's go to it. Okay, so this is your large box. Let's go back to this one. These are your large boxes, okay? Say you had another R wave. After this, you'll have your P and then your R, okay? So you count the number of large boxes between 2 R waves. Between 2 R waves, which would be this. So you count the number of large boxes and divide 300 by the number of boxes, the number of large boxes, to get your heart rate. Another method, count the number of small boxes between the 2 R waves again, and divide that number by 1500. So when you count the small boxes between the RR, you divide into 1500, or divide 1500 by the number of small boxes. Another method, divide 300 by the number of large boxes. So that's how you do your ECG. we're going to be setting up some practice for you in your different classes to practice doing the heart rate. All right, so we decide how we're going to determine the rate. That's the first thing in doing your ECG strip. Then we determine how we're going to do the rhythm. How are we going to calculate the rhythm? First thing you need when you're analyzing your ECG is calculate the rate. Okay, and we look at 3 ways to calculate the rate. Now we're going to look at how we're going to determine if the rhythm is regular or not. The R interval is used to determine ventricular rhythm. And the PP interval is used if we're looking at atrial rhythm. Remember, we can count atrial rate too by the same methods that we discussed, but we would look at P waves because atrial contraction is evidenced by a P wave, okay? So if we are determining the rhythm, say we're doing the ventricular rhythm, we're gonna look at the intervals between the R waves and see if the intervals are the same throughout. Okay, so let's look at this one. We're determining the ventricular rhythm. This is one R wave. Remember, your QRS is for your ventricle, okay? So this is one R wave, this is another R wave, this is another R wave. You can measure these. You measure the distance. Sometimes physicians or nurse practitioners will use a caliper, or the cardiologist will use a caliper to measure. But a simple measure is you just get a strip of paper, or you can use a ruler, and you try to measure the distance to see if the distance between this and this is the same as the distance between this R wave and this, is the same between this R wave and this, is the same between this R wave and this. The distances look like the same. Another way you can do is count the boxes between each to see if the distances are the same, okay? So if the distance between the R waves are the same, you say that the rhythm is regular, okay? And that's very simple. Count the distance between the R waves to determine the rhythm. So distance between the R waves will tell you if the rhythm is regular. So this first strip has a regular rhythm. Distances are equal between your R waves. Now look at this one. Is this rhythm regular? Look at your first R wave and look at this distance between it. I don't even have to measure this one to tell you that this rhythm is not regular, because this distance is different from this distance, and this one is different from this distance. Look how wide apart this is compared to this. So the distance between the R waves in this second strip is not the same, okay? While this one is the same. So we said our first strip, the rhythm is regular, and our second strip, the rhythm is irregular. So we have learned how to start interpreting our ECG. We have learned how to determine the rate, the heart rate, from the ECG, and we have also learned how to determine the rhythm from the ECG. Now we're going to look now at some dysrhythmias. And first we're going to look at our sinus rhythm. And remember, we say sinus rhythm originate from our sinoatrial node, okay? So normal sinus rhythm occurs when the electrical impulse starts at a regular rate and rhythm in the sinoatrial node and travels through the normal conduction pathway. That's what we call our normal sinus rhythm. Normal sinus rhythm has the following characteristics. The ventricular and atrial rate is 60 to 100 beats per minute in the adult. We discussed that already. So we say that's a normal sinus rhythm. The ventricular and atrial rhythm is regular, so the rate has to be normal. The rhythm has to be regular, and that's the two things on the ECG we've completed so far, rate and rhythm. Now the QRS, which we looked at, the shape and duration should be normal, and the P wave should have a normal and consistent shape. And we always have a P wave in front of a QRS complex because it is P, Q, R, S, T. Okay, so the P wave has to precede the QRS complex in order for us to say this is a normal sinus rhythm. Okay, the PR interval now that we looked at between the beginning of our P wave and the beginning of our QRS complex, that PR interval should be consistent and should be between 0.12 and 0.20 seconds. And the P to the QRS ratio should be 1:1. You should have a P wave for every QRS complex because it is P, Q, R, S, T. Okay? So this is our normal sinus rhythm. And remember I mentioned the isoelectric line? So you can imagine a line going right across on your ECG. That's our isoelectric line. And you have positive deflection, which is above the line. So anything above the line is considered positive deflection. And below that line is a negative deflection. So your P is above the line, your R is above the line, your T is above the line. So those are positive deflection. On the line, you'll have usually your PR and you have your ST on the line, okay? And below the line, you have your Q wave and your S wave, okay? So this is your normal sinus rhythm. And if you look at this one, you see it flowing normal. We do have our P wave before our QRS, followed by our T wave. Then you have your P wave again, your QRS, and your T wave. Your P wave, your QRS, and your T wave going right across. So that's what we call a normal sinus rhythm. The rate, say this is a 6-second strip. This would have been 50. Okay, so this is not a 6-second strip. So this would have been 50. But the rate is normal on your normal sinus rhythm, and the rhythm is normal, meaning that your R waves are equal distances apart. All right. So sinus bradycardia is our first abnormal rhythm that we're going to look at. And in sinus bradycardia, it originates from the sinoatrial node. You do have your P, Q, R, S, T. Okay, so you have your complete complex right here, your atrium, your ventricle complex, and the rate, however, is slow. Okay, so with sinus bradycardia, the locus of stimulation is the same as normal sinus rhythm, just now the rate will be less than 60. Recall that brady means slow. The only difference between sinus brady and the normal sinus rhythm is the rate. All other steps in the rhythm analysis are normal. So if you find a patient with sinus brady or in your exam, they may show you this rhythm and ask you what this rhythm represents. okay? If you're not sure, just by looking, and if you think that this is a half of a strip, although you see your right here would be 3, so this actually is your 6-second strip, okay? So if you are not sure though, and you're confused about this, because I know students have seen this rhythm and like, how could I count the heart rate? Remember, you have more than one ways of determining the heart rate. You can count the number of large boxes. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay? And if you count the number of large boxes, you divide what by that number? Okay? You divide 300 by that number. Okay? So you can check the heart rate from counting the number of large boxes. Okay? Management of sinus brady. You give atropine. Atropine is an anticholinergic drug. Okay? We know that acetylcholine can slow the heart rate. Okay? Because if the vagus nerve is stimulated, you can get sinus brady. If the vagus nerve is stimulated, what happened is that it releases acetylcholine. Okay? That's a neurotransmitter that's released when your vagus nerve is stimulated. And that is why, say you're nervous for a test. You can do what we call the Valsalva maneuver to slow your heart rate. So you're nervous for a test, you take deep breaths and you hold it and you bear down. What that is gonna do is stimulate your vagus nerve, and acetylcholine is gonna be released. Acetylcholine is gonna slow your heart rate. Remember that acetylcholine is your main neurotransmitter in the parasympathetic nervous system. Parasympathetic slows down your heart rate, while sympathetic speeds up your heart rate. Okay, your sympathetic would be like your epinephrine, your norepinephrine, your adrenaline. Okay, those speed up your heart rate, but acetylcholine slows your heart rate. Okay, and so again, let's go that over one more time. Influences on the heart rate. You have your sympathetic and your parasympathetic influence. Okay, your sympathetic is going to produce your what we call your catecholamines. Catecholamines are like your adrenaline, your epinephrine, and your norepinephrine. Those are your catecholamines, which are produced in your sympathetic nervous system. Those constrict blood vessels, so those speed up your heart rate. The opposing effect now is your parasympathetic effect. Your parasympathetic system, your main neurotransmitter in that system is your acetylcholine. Acetylcholine is going to slow your heart rate down. So if patients are having a bradycardia, one of the things we can do is block acetylcholine. Okay, and what do we use to block acetylcholine? It's going to be an anticholinergic drug. Here you see your atropine. It is an anticholinergic. So 0.5 milligrams of atropine is given rapidly as IV bolus and repeated 3 to 5 minutes until a maximum dosage of 3 milligrams is given. Okay. Also, remember we said that epinephrine can speed the heart rate up, and dopamine is another neurotransmitter that can speed the heart rate up. So in sinus bradycardia, we need to increase the heart rate. So you can give atropine, you can give dopamine, you can give epinephrine. Okay. Now sinus tachy. The only difference between normal sinus rhythm and sinus tachy is that the rate exceeds 100 beats per minute. But you do have all other components of a normal sinus rhythm present, like your PQRS. But the rate now is fast. Tachycardia means fast. So you need to slow this heart rate down, right? And we know already that there are certain drugs that slow the heart rate, like our beta blockers. And that's why when we're giving drugs like metoprolol and atenolol, we have to do the pulse rate before we give them, right? Because they slow the heart rate. So we can give beta blockers and also calcium channel blockers to slow the heart rate, okay? We also have adenosine, which is considered if the QRS is monomorphic, which is uniform in shape. Here we see our QRS is uniform and the ventricular rhythm is regular. Otherwise, procainamide, amiodarone, and sotalol are given. Now, atrial flutter. We're looking now at our atrial rhythm. Atrial flutter. Note the sawtooth appearance. Each flutter wave represents atrial depolarization. This will be noted next to the P wave in rhythm analysis. Instead of P waves, this tracing has F waves. Management. Adenosine is given intravenously by rapid administration and immediately followed by 20 mL of saline flush and elevation of the arm with the IV line to promote rapid circulation of the medication. Anticoagulants may also be given and cardioversion done for atrial flutter. Later on, we'll look at cardioversion. And anticoagulant is given because these patients may develop a clot because the atrium is not contracting as it should. It's barely shaking, okay? But anticoagulant is even implicated greater in atrial fibrillation. So we look now at atrial fibrillation. So remember your flutter waves for atrial flutter or your sawtooth appearance. Atrial fibrillation. When a patient experiences AFib, the atria are not really contracting as they normally would. They're barely shaking, okay? They're barely shaking. And patients with atrial fib, they're at increased risk of heart failure because the atrium, they are shaking. They're not contracting to push the blood out, so we have stasis of blood because it's really shaking. And therefore, they can develop clots. And these clots can cause a myocardial ischemia if it goes up into the aorta, down into the coronary vessels. It can cause a myocardial ischemia. It can also go to the brain and give patients a stroke. Management of AFib. When patients have AFib, conversion to a normal sinus rhythm is necessary. They can use pharmacological agents to convert AFib to a normal sinus rhythm. And these drugs are like your flecainide, dofetilide, propafenone, and amiodarone. Also, because they're at risk for clot formation, antithrombotic drugs can be given, like anticoagulants, antiplatelets. Oral antithrombotic therapy is also indicated for most patients with non-valvular atrial fibrillation because it reduces the risk of stroke. We're going to look at our ventricular rhythms. First one we're looking at is our VTAC. Okay. And in VTAC, you look for rhythm that is irregular with heart rate that is fast, 100 to 250 beats per minute. And notice that the P wave is absent when you have VTAC because these ventricular waves are so wide, they cover the P wave. The P waves are absent, okay? The PR interval is not measurable. The QRS is typically wide, greater than 0.12, and bizarre in appearance. Ventricular tach can be monomorphic, okay, or polymorphic, in which the QRS forms will vary. So this is your VTAC, okay? You notice that the waves too are taller. You can use that to remember they're higher than when you have your atrial dysrhythmias. You notice that you're seeing the ventricles in your atrial dysrhythmia, you're seeing the ventricles clearly, your PQRS. I usually tell my student, if you can see your PQRS clearly, then it's not a ventricular fib. Look at your atrium. So when you're looking for the atrial dysrhythmias, look what your atrium looks like, because I know a lot of students have difficulty interpreting their ECG. Look what your atrium looks like, your P waves. Okay, you see them fluttering in atrial flutter. So your QRS is not affected. Notice your QRS, these are your ventricles. So you know your ventricles are not affected. So you look if your ventricles are affected. And then you look if your atrium are affected. So look what is happening to your atrium. Again, look what is happening to your atrium. Okay? And now you're not seeing your atrium when it's a ventricular tachy or even ventricular fib. You're not seeing your atrium. So in ventricular tachy, the waves are regular, because if you look, they're same distance apart. So these are your ventricular waves. The heart rate, however, is fast and the P wave is absent in your ventricular tachy. Management, procainamide and sotalol may be used for monomorphic stable VTAC, and IV amiodarone is a medication of choice for a patient with impaired cardiac function or acute MI. Can also use lidocaine, ablation therapy. And ablation therapy is when they destroy certain cells, certain cardiac cells that's responsible for the dysrhythmia. They can do ablation therapy. Cardioversion can be done and defib, and we're going to look at those later. Now in VFib, this is what your VFib looks like. Remember, in any fibrillation, the ventricle is not contracting as it should, and so the waves are not going to be as high as your tachycardia. Okay? The ventricle is just fibrillating, just shaking. Okay? And you're not going to see your P waves again. So look for a rhythm that is highly irregular, and you can differentiate it between VTAC, because VTAC, the waves are regular, okay? But in both cases, your P waves are missing. But in VTAC, the waves are regular. In VFib, look how irregular they are. Look at these compared to these, okay? So in VFib, the rhythm is irregular and the heart rate cannot be measured. Notice that the P wave is also absent and the PR interval is not measurable. The QRS is typically not measurable either. And ECG tracing is going to show you a wavy line. Management of VFib. Early defib is critical to survival, with administration of immediate cardiopulmonary resuscitation until defib is available. So we can do bystander CPR until the defibrillation is available. For refractory ventricular fib, we have to administer amiodarone and epinephrine to facilitate the return of spontaneous pulse after defib. So note your drugs that you give for these different conditions. Sometimes you're just given these waves in your exams, and then you will be asked, if a patient presents with this wave, what medication could be implicated for this patient, okay? Premature ventricular contractions. These are premature. They occur before they should. These ventricular contractions occur before they should. Okay, generally speaking, premature. So PVCs are characterized by premature and bizarrely shaped QRS complex. Remember, your QRS is your ventricles, okay? And they are unusually long and appear wide on the ECG. Look at your QRS, okay? These complexes are not preceded by a P wave, and the T wave is usually large and oriented in the opposite direction. So remember your T wave. Your T wave usually is in the same direction as your QRS, okay? Or as your QRS complex. But in PVC, it's in the opposite direction, okay? So this is your PVC. And your PVC is similar. The patient will feel like they miss a heartbeat, like their heart skip a beat, and that's considered to be a PVC, okay? And PVCs might not be harmless. It can be in response to certain medications that we take, or certain emotion, anxiety, caffeine, even some other drugs like illicit drugs can cause a PVC, okay? So PVCs in and of themselves may not be harmless, but if you start having several PVCs, then that is a problem. Say if you have 2, that may not be harmless, but 3 and above, then you start looking a little bit closer on them. Management. PVCs that are frequent and persistent may be treated with amiodarone or sotalol, but long-term pharmacotherapy for PVC is usually not indicated. We have this other rhythm called ventricular bigeminy and trigeminy. Now, in a rhythm referred to as bigeminy, every other complex is a PVC. So these are similar to PVCs, but based on how the pattern of the PVCs, we call them bigeminy or trigeminy. Let's look at bigeminy. We said every other complex is a PVC. A complex is your PQRS, right? So here you have one complex and a PVC, a normal complex and a PVC, a normal complex and a PVC. So every other one is a PVC. So you have a pair right here, normal and PVC, normal and PVC. So that's what is called a bigeminy. Bi means 2. So you have 2 complexes together. This is a pair, a normal, a PVC. It's another pair, normal, a PVC. Another pair, normal, a PVC. So that's your ventricular bigeminy. Now, ventricular trigeminy, you can well imagine what it is. You have every third complex is a PVC. So you have 3 friends walking together, 2 normal and a PVC. 2 normal and a PVC. So this is 3. Normal, normal, PVC. Normal, normal, PVC. Normal, normal, PVC. Normal, normal, PVC. So that's your ventricular trigeminy. The patient may say that their heart skip a beat, when they have this trigeminy. Again, your treatment will be your amiodarone, sotalol, okay? And these rhythms can be dangerous because they can proceed, patients can progress to having ventricular tachycardia when they have so many PVCs. Another rhythm, which is a lethal rhythm, is your torsades de pointes. So this can be a lethal rhythm. It is a polymorphic VTAC preceded by a prolonged QT interval, which could be congenital or it could be acquired. Now, look at the pattern of this rhythm. Okay, you look at these shorter ones, these higher ones, these shorter ones, these higher ones. So they describe this rhythm as the outline looks like a party streamer. You know those decorations that they use at parties, party streamers that are twisted around? Look at this green one. It looks like a party streamer. And so that's how torsades de pointe. I know it's French and I may not be pronouncing it properly, but it's a lethal rhythm, and this is what it looks like. So if you see this rhythm, you know that this is a fatal or a lethal rhythm. Common causes include central nervous system diseases, certain medications, low levels of electrolytes like potassium, calcium, magnesium. Now, I wrote down here, this rhythm may be found in alcoholics due to magnesium deficiency. Alcoholics tend to be malnourished, and so alcoholics may be deficient in magnesium. So this is a rhythm that may be present in alcoholics due to their magnesium deficiency. So you know, to treat this rhythm, you'll have to correct the causes. Give magnesium, calcium, or potassium, okay? Now, asystole. Every student would hope to get this one on their exam, asystole. Ventricular asystole is treated in the same way as pulseless electrical activity, focusing on high-quality CPR with minimal interruptions and really identifying the contributing factors for asystole. Okay, so it would be CPR for this patient. Now we're going to look at our conduction abnormalities. We have the first degree AV block, and this occurs when atrial impulses are conducted through the AV node into the ventricles at a slower rate than normal. So we say this is a first degree AV block. When they reach the AV node, they are slowed down, okay? And so if they are slowed down, they are not going to reach the ventricles in time. Note that the PR is constant, but the PR is greater than 0.20 because it is slowed down. PR is when the impulse goes from the atrium. Atrium is P, is represented by your P wave. R is a ventricular wave. So PR interval, remember we looked at our PR interval. So right there, the impulse is slower than usual. And so the PR is going to be constant, but it's going to be greater than 2 seconds, 2.2 seconds, because it is slower. The impulse is slower. Okay, so here is showing you the PR interval, which is prolonged. Okay, and that's your first degree AV block. In summary, the PR interval is prolonged in your first degree AV block. In your second degree AV block, type 1, they call that Wenke back. You have an progressively longer PR duration until there is a non-conducted P wave. So let's look at it. Remember your PR from the beginning of your P wave to the beginning of your QRS complex. And we said in second degree AV block type 1, your PR is progressively longer. So look at your first PR. Look at the width of it. Then look at your second PR. Look at the width of it. You notice that this one now is wider than your first one. And look at your third one is even wider. Okay, so it gets progressively wider, your PR interval. Okay, until you have a P wave that is not conducted to your ventricle. So your P wave begins and the impulse is not conducted. So here you lose your QRS right here. Okay, so you remember that a P wave should precede a QRS. Okay, but this impulse is not conducted. Okay, so you have lost a QRS right here. Okay, so you have progressive, progressive, progressive drop. Okay, and then it starts again. Progressive. So you have long, longer, longest drop. And that's how it continues in your second degree AV block type 1. Long, longer, longest drop. Long, longer, longest drop. So you don't have a QRS after this P wave. It has dropped your QRS. So that's your second degree AV block type 1. In your second degree AV block type 2, you have constant PR interval and the presence of more P waves and QRS complex. Let's look at it. So your PR intervals are constant. See them looking alike? Okay. So you have constant PR interval, but you have more P waves than your QRS complex. Look at that, P wave. You should have a QRS, there is none. P wave. Okay, no QRS. Then you have another P wave. So you have more P waves than your QRS complexes, but your PR intervals are constant. And this is your second degree AV block type 1. Type 2, I'm sorry. Second degree AV block type 2. Now your third degree AV block, which is our last one, you do have irregular PR intervals. So look how wide this PR interval is. Look how narrow this one is, and look at this one. There are irregular PR intervals. Okay. Now question, the nurse is preparing a male patient to have a 12-lead ECG performed. When prepping the skin, the nurse notices that the patient has abundant chest hair. What is the most appropriate nursing intervention to improve adhesion of the leads? Give you a couple seconds to read it. It is clip the hair with the patient's permission before applying the lead. So your rationale, alcohol should not be used to prep the skin because it increases the skin's electrical impedance. Remember we discussed electrical impedance of the skin, thereby hindering the detection of a cardiac electrical signal. Clipping the hair would provide access to the skin to assist with adhesion. The ECG would not be performed correctly if the leads were only placed on the extremities, and there is no need to reschedule the ECG at this time. So that was your question. and that's irrational. Okay, collaborative problems and potential complications. These patients with dysrhythmia, they're at high risk for cardiac arrest. Okay, they're at risk for heart failure, and they're also at risk for thrombotic events, especially with atrial fibrillation. Remember, in AFib, the heart is not contracting, it is barely shaking. And because it is shaking, quivering, then there is stasis of blood and clot formation. And so they can have a myocardial infarct, they can have a stroke and other thromboembolic events because of AFib. And that is why thrombolytics may be used or anticoagulants may be used for patients with AFib. Now, care of patients with dysrhythmia. Your nursing interventions, you monitor and manage them. You know you'll have to do their vital signs. You'll have to monitor their ECG. They're going to be anxious, so you institute measures to reduce anxiety, promote home and community-based care when they're going home, and educate them about self-care, what they should avoid, and continuing care. So you assess their vital signs on an ongoing basis. Assess for lightheadedness. Some patients may get dizzy, some may be having fainting spells, and if they're hospitalized, we obtain their 12-lead EKG and we do continuous monitoring for them if they have this arrhythmia, because they can have an abnormal rhythm at any point in time. So we want them to be on continuous monitoring. And anti-arrhythmic medications will be given. We have to know the side effects. We have to know how to give them. We have to be prepared to monitor these patients and also educate them about their medication. We stay with them. We maintain safety and security. We discuss emotional response to dysrhythmia, and we help them to develop a system to identify factors that contribute to episodes of dysrhythmia, and we maximize our patients' control. We try to educate our patients too, tell them about the treatment options, about therapeutic medication levels, and how to take the pulse before medication, how to recognize symptoms of dysrhythmia, measures to decrease the recurrence, and the plan of action in case of an emergency. We may also have to educate the family on how to perform CPR in case they need to do it for their loved one. And we have to refer these patients for home care, and they may be hemodynamically unstable with signs of decreased cardiac output. And they may also have significant comorbidities and socioeconomic issues and limited self-management skills. So we have to teach them self-management skills and some evaluation for these patients. We want them to maintain adequate cardiac output, stable vital signs, and we want them to be free from signs of dysrhythmia. We want them to have a decrease in their anxiety, a positive attitude, confidence in their ability to act if an emergency occurs, and to express understanding of dysrhythmia and treatment. Your second question. Nurses assessing a patient admitted with a heart block. When placed on a monitor, the patient's electrical rhythm displays as progressively longer PR durations until there is a non-conducted P wave. Which type of heart block does the nurse expect this patient to have, or that this patient is having? Did you say second degree type 1? If so, you are correct. Okay. Now we're going to look at adjunctive modalities and management. When medication alone are ineffective against dysrhythmia, adjunctive modalities will be needed. Okay, so we aim to give our patients medications first. We did look at several medications. Beta blockers are mainstay. We give amiodarone, we give or sotalol, we give or procainamide or lidocaine, okay? But when those medications are ineffective, then we have to use other means. And these are what we call our adjunctive modalities. These are like our pacemakers. This is like cardioversion and defibrillation. Cardioversion and defibrillation are used to treat tachydysrhythmias by delivering an electrical current that depolarizes a critical mass of myocardial cells. And we know what depolarization means. The poles have now changed. So we depolarize the cells and allow them to repolarize. So when they repolarize or they go back to rest, the sinoatrial node is able to recapture its role as the heart's pacemaker. So that's what we do in defib and cardioversion. Depolarize, deliberately depolarize these cells that are fibrillating or fluttering. Okay, we contract them ourselves. And so when they repolarize or go back to rest, the sinoatrial node, which is the heart's pacemaker, the heart's natural pacemaker, is able to recapture its role as the heart's pacemaker. Your concept mastery. The difference between cardioversion and defibrillation. This you have to know for your NCLEX for any exam. The difference between cardioversion and defibrillation is the timing of the electrical current, okay? Again, the difference between cardioversion and defibrillation is the timing of the electrical current. Cardioversion involves the electrical current that is synchronized with the patient's ECG. So in cardioversion, you typically have to have your ECG rhythm, okay? And the current is synchronized with that ECG. In defibrillation now, the current is immediate and it is unsynchronized. So if the patient has an ECG rhythm, then they're gonna do cardioversion. If they don't, they're gonna do defibrillation. So that's the difference between both, because students tend to ask a lot about these differences. They sound alike because you use the defibrillator for both, but when you're doing cardioversion, you're gonna turn the synchronizer on. Okay, remember that. With cardioversion, the synchronizer is turned on and the patient usually have to have a pulse or ECG. Okay, in defib, they do not have an ECG rhythm. And so it's not synchronized with the rhythm. Pacemakers. Pacemakers are electronic device that provides electrical stimuli to heart muscles. Pacemakers are used when patient has a slower than normal impulse formation or a symptomatic atrioventricular or ventricular conduction disturbance. Types of pacemakers are permanent and temporary pacemakers. Pacemakers need replacement when the battery is depleted, or some has batteries that can be recharged. Some, the battery cannot be recharged, so the pacemaker will have to be replaced. Emergency pacing may be done also with transcutaneous pacemakers, which most defibrillators now are equipped for emergency pacing. And the impulse travels through the skin and can cause discomfort when they're doing transcutaneous pacemakers. Here's a picture of a transcutaneous pacemaker, okay? Here you have an implanted pacemaker. So the pacemaker lead enters the external jugular vein, and it is tunneled between pacemaker and the external jugular vein. And you have a generator that's placed beneath the skin. Okay. And notice the tip of the electrode. It's in the apex of the right ventricle. So that's your implanted transvenous pacemaker. The pacemaker paces the atrium and then the ventricle when no ventricular activity is sensed for a period of time. So that's what your pacemaker does. A straight vertical line is usually seen on the ECG when pacing is initiated. So this is a straight line. And they call this a pacemaker spike. Okay. The appropriate ECG complex should immediately follow the pacing spike. So if you're pacing the ventricle, then you have the spike and then the QRS complex. So if you're pacing the atrium, then you have the spike in front of your P wave, okay? So here you have the spike right in front of your QRS. So this is pacing the ventricle. Remember that the appropriate ECG complex should immediately follow the pacing spike. Therefore, a P wave should follow an atrial pacing spike, and a QRS follow a ventricular pacing spike. And a pacemaker spike is just a straight line, a vertical line that shows you that pacing is taking place or pacing is initiated. And if it's the ventricles you're pacing again, the spike is going to be before your QRS. If it's the atrium that you're pacing, the spike would be before your P wave. Okay. Complications of pacemaker use. Infection is a big complication and bleeding. Okay. There can be dislocation of the lead, skeletal muscle, or phrenic nerve stimulation. Cardiac tamponade is a big one too. And the pacemaker can malfunction. And some of the things that make your pacemaker malfunction, we're going to look at them. So when a patient has a pacemaker, we monitor for pacemaker syndrome, which is chest discomfort, shortness of breath, fatigue, activity intolerance, and postural hypotension. We also assess for pacemaker malfunction. They may have bradycardia and decreased cardiac output. We try to avoid exposure to strong electromagnetic field, and we have to educate our patients on these because they can get electromagnetic interference. Recent pacemaker technology allows patients to safely use most household electronic appliances and devices like your microwaves, ovens, and electrical tools. Gas-powered engines should be turned off before working on them. And objects that contain magnets, like the earpiece of a phone, large stereo speakers, and jewelry that contain magnet should not be near the generator for longer than a few seconds. Patients are advised to place digital cell phones at least 6 to 12 inches away from the pacemaker. Magnetic resonance imaging, radio and television transmitter towers and lines, transmission power lines, and electrical substations may cause electromagnetic interference, and welding and the use of a chainsaw should be avoided when they have a pacemaker. So we've looked at our pacemakers as an adjunctive modalities for dysrhythmias. We also have defibrillation that we can use. Defibrillation is used in emergency situations as a treatment of choice for ventricular fibrillation and pulseless VTAC. The most common cause of abrupt loss of cardiac function and sudden death is our ventricular fibrillation. Defibrillation is not used for patients who are conscious or patients who have a pulse. Remember what we say if they have a pulse, what we would use? Yes, we would do cardioversion if they have a pulse, not a defibrillation, okay? So now let's look at electrical cardioversion. This involves the delivery of a timed electrical current to terminate a tachydysrhythmia. In cardioversion, the defibrillator is still used, but it is set to synchronize with the ECG on a cardiac monitor so that the electrical impulse discharges during ventricular depolarization. The synchronization prevents the discharge from occurring during the vulnerable period of repolarization. Okay? Patients with dysrhythmia for more than 48 hours will receive anticoagulant before they do a cardioversion. Okay? So we've looked at cardioversion and we've also looked at defibrillation. Treat tachydysrhythmias. Both of them treat tachydysrhythmias by delivering electrical current that depolarizes a critical mass of myocardial cells. We have said this already, okay? And when the cells repolarize, the sinoatrial node is able to recapture the role as the pacemaker. So here we see how we place the paddles for defibrillation. These are two different placements. So on the anterior chest, we place them in that position, and we can also place on the posterior and on the anterior chest. Note these diagrams. These are your hotspot diagrams for paddle placement. And remember that the paddle has to be adherent, have strong adherence to the skin, okay? So safety measures. Ensure good contact between the skin and the pads and the paddles. So we use a conductive medium, 20 to 25 pounds of pressure, and place the paddles so that they do not touch any bedding or clothing and are not near medication patches or oxygen flow. If cardioverting, again, we cannot overemphasize that you turn the synchronizer on. And that's a good NCLEX question. What do you do before you start the shock in cardioversion? You turn the synchronizer on. If defibrillating, you turn the synchronizer off. And do not charge the device until ready to shock. We have to call clear how many times? 3 times. And we follow checks required for clear. We ensure that no one is in contact with the patient, the bed, or the equipment. So that's your cardioversion and your defibrillation. We also have an implantable cardioverter defibrillator. Okay, we looked first at our external defibrillator when we discussed this just now. But now we're going to look at our implantable cardioverter defibrillator. This is a device that detects and terminates life-threatening episodes of tachycardia and fibrillation. Okay. And here you see in this picture the implanted cardioverter defibrillator. That's what you're looking at right there. So let's look at nursing management after these permanent electronic device insertion. Have to monitor their ECG and chest X-ray, and we assess their cardiac output, and we assess the incision site. Bleeding is a possibility, so we assess the site for bleeding, okay? Signs of ineffective coping, level of knowledge, and educational needs of the family we also have to assess and also address, okay? So this is your lecture on dysrhythmias and conduction problem